أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين. إياك اهدنا الصراط المستقيم، صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Jazakallah khair for the recitation. Now we'll move straight into the session, and I would like to take this opportunity to invite Dr. Abdullahi to begin. So, Doc, kindly confirm you can hear me well, and also you could share your screen.
Yes, I can hear you very well. So inshallah we'll start. We are supposed to have also Dr. Bill on board, and nimeongea na yeye tonight. His schedule is a bit busy. Kuna meeting you'll have with Prof. Ndwati anytime, but nimemwambia inshallah to join anytime that he will join inshallah. For the meantime, there's a presentation I've prepared, and we'll tackle inshallah, and Doc was supposed to now add comments, corrections, anything yenye inatakikana. So let me share my presentation. Haya, so mtaniambia inshallah kama you can see. Mnaweza ona? Is it feasible?
On my end, I'm not seeing it. Maybe someone else in the meeting
Acha
to
nirudi
confirm.
hapo. Can it be seen? Ama sija share screen? Hebu ngoja.
bado hajashare.
Sawa Doc, just a minute. Just a minute. Ngoja niko kutumia laptop. Let me see. Hebu ngoja share. Good. Sawa. Sawa. Iko sawa. Sawa. Second slide. I think my introduction is obvious. This class who doesn't know me, unless me, I don't know some people. So today's presentation is about OSCE session for pediatrics level 5. And this is the first time mtakuwa mnafanya OSCEs. I hope I'm audible. Sindio? Anytime sisikiki mtani, feel free kunisimamisha. So this is the first time you are doing OSCES, and welcome. So basically OSCES is just it's an objective structured clinical examination to evaluate the candidate on how best their clinical skills are, because at the end of the day, he or she will be a doctor, and there must be the clinical skills that will help the patient. So what is the instruction? What is the structure of the exam? What am I expected to know? What am I anticipating when I go inside there? That is the main scope of today, and I've tried to make it simple so that at the end of the day, inshallah, you pass, and everyone passes OSCEs. 50 year, 60 year people pass OSCEs, and you can even do well when you already know the tactics, what to do, and how to survive. So the time will, for pediatric, the stations are 8 stations, which I will cover in the next slide. Each station is 10 minutes. The max for the station, I think ikienda sana 20-25. What am I expected sasa kupatana nikiingia hapo ndani? Variety of things, obvious, the mannequin for neonatal resuscitation. Expect some lab results utapewa, because as a doctor, you must know how to interpret lab results, an X-ray, a growth chart, and random pictures of case-based. So instruction, Tambo, read and understand the given tasks and perform them. You are being watched and assessed on your skills. Talk as you undertake the skills. Yeah, so each station, there's the instructions that you'll be given. So we can go to the next slide. So what is the structure now? These 8 stations that I have mentioned, how are they distributed? Is it written? Is it what is it? Someone, the first thing before even we start to tackle these questions. So your 8 stations are made up of these things that I've made up. So before you go, as you are preparing now, because towards the end, everyone is preparing for OSCEs in their group discussions, the first thing is systemic examination. As a doctor, 50 year, 60 year, always. Sometimes even pediatrics, they might not ask you, but know your systemic examination in every system, because pediatrics is physician of young babies or children. So you must know your systemic examination, GI, cardio, whatever it is, just have an idea. The second thing is, this one lazima utaulizwa, a targeted history, which all of these things will do them practical one by one tutazipitia. So a targeted history taking, utaulizwa history taking in any of the system. One sample, I will do it hapa, mtaona. Then that is one section. The other section is my connection. Am I audible?
You're very audible.
Okay, so anytime tu mnanisimamisha, please. So the other one is analysis station. Kitu inaitwa analysis is the examiner wants to know your analysis skills, because as a doctor in future, I think 2 weeks ago, I had a friend who got a job in the Kenya Airways. So one of the mornings, alinipigia, doc, I did my CBC and I needed your interpretation. I want to take it to my boss. So as a doctor, lazima ujue to interpret some basic things, not only for your exam, even in future. So if that day my friend came and I don't know how to interpret a CBC, that's an embarrassment. So simple things, lazima that exam will have an X-ray, will have a growth curve. Those are analysis. Laboratory tests, which I've already mentioned, basics, CBC, UEC, LFT, you must know. Alafu, the other section is neonatology. Neonatology is very important in pediatrics. So kuna questions on neonatology itakuja, which neonatology has only 5 topics. We can mention them at a size. So the main that they love is neonatal resuscitation. Hiyo ni lazima. Sometimes they surprise people. They can ask you, like our time, insert an NG tube. So in a pediatric. So neonatology ikona some topics yake, which will, all of this will do examples one by one. Neonatal jaundice. So things of neonatology, the 5 topics of neonatology, jipange nazo vizuri. The other part is child health. Hiyo ni free marks. Child health will have like 2 stations, lazima. Vaccinations, pneumonia, diarrhea, water sanitation. It's a question that walituliza sisi that I will do it hapa. So child health, usiende huko kama hujajipanga na knowledge ya child health. Alafu kuna random based, case based pictures, random, which will do them. So we can be given a case of picture ya mtoto akona measles. From there now questions come. Sisi walituuliza encephalocele, which will do it sahizi, rickets, hivyo. So the exam of the scope inachezea tu hapa. So when you are revising, make sure all these things they are at your fingertips. So we can go to the next slide. So these are just tricks on how to survive OSCEs. OSCEs, you must have the expected knowledge, and also kuna some critical things that will make you impress the examiner. Because at the end of the day, all these stations ni examiners wameka, and these people are human beings. You might know things, but if you are not confident, you cannot speak well. So no, somebody else might maybe anajua kiasi, but they have the confidence. So confidence ni kitu moja muhimu sana. Alafu understand the question very well, please. Ukifika kwa hiyo station, it is 10 minutes. Take your time, pole pole, understand hii swali inauliza nini. Perform a neonatal resuscitation. Is it for a child with signs of life? Is it an older child? Is it just delivery money? So you need to understand vizuri. Isikue, because some examiners are so malicious, wananyamaza. So from the word go away, hujaelewa equation. You're doing your own thing, time is going. So understand the questions, be confident, and the pediatric questions ziko, tutafanya saizi. Kuna like tuseme a case of cerebral palsy, tutafanya saizi. Kuna part A, B, C na D. Let's see part A haujui. Don't dwell on part A. Just skip, go to part B, C, D, jibu zote, alafu kutakuwa na extra minutes kama 4-5 minutes. Unaambia sa examiner, can I go back to question A? Unarudi to question A, unafanya pole pole, unamaliza. But if you are stuck at A, unapoteza marks. Na labda A is 2 marks. Kuna B, kuna C haujafanya. Or sometimes umefanya zote vizuri, but umeona bado uko na time, unaambia, can I go back to question A? I feel maybe hapo nilisahau some point. You are allowed. So, alafu, sometimes be sharp when prompted is, you can go to an OSCE when binadamu, umeteleza labda kidogo. So the examiner is giving you a chance. This is an indication from the examiner. So don't be so fixed-minded that the examiner cannot help you. Kuna kitu anafanya, or umeanza kusema point, ameanza kunod the head. So unaona hapa I'm on the right track. Let me go on with these points. So when prompted, learn your environment. What's going on? What is the examiner? Some examiners, they don't want to talk to you. So we pia usiogope. Just as long as you have your facts, do what is needed, give your best. Alafu, in each station, give your best. So this give your best. In Izakwa, you started with station 1. Mambo imeanza kwa kidogo, but you have 7 other stations. The next when you go with an open mind. So nasikika? Hello,
Yes,
nasikika?
Yes, unasikika.
Please, anytime sisikiki, just let me know. Each station give your best. Forget stations. At the end of the day, you need 4 or 5 good stations and you pass. Second, so these are now vitu nimecompile to give you now the real practical scenarios. Isikuwe tu I've just spoken, alafu you're like, sasa amesema tu hivi, but how should we tackle? So this is like a random case-based picture. So these pictures ziko nyingi sana kwa Priyanka. So take your time. Usiingie exam kama hujapitia as many pictures as possible. With obvious some knowledge by now, ushasoma, you know all these cases. So orient yourself with picture. So now you can be given a picture like this. Umeingia to station 1, unapata I got Dr. Laigong. It was the second case nitaonesha. Amekupatia picture, anakwambia soma question, answer. So you'll find something like this. A picture of a girl standing. Most likely, after this one, I just got from the internet because these are just 2022 compilation ya Priyanka nilitoa huko. So ukipata kitu kama hii, you just relax, angalia what is this picture. Pediatrics wanapenda picture. So jiulize hii picture what am I seeing? After that, utakwambia describe. Me, I remember during my time kulikuwa na a case of encephalocele, which I'll present next, na a tonsillitis, which is common tonsils for us when tulikuwa Moyale uliona tonsils is common in the age group of 8-year-olds, watoto hapo. So whatever umepatiwa hapo, just relax. After you analyze the picture, answer the question. So watakwambia, describe the clinical presentation you see on the picture. Give two differentials. What is the anatomical basis of this presentation? Name one radiological investigation for this. So I want us to understand practically sasa hii kitu inafanyikaje. So kama this one, utasema, this is a picture of I can see here a baby, which there's an abnormal gait here. And yeah, so you describe anything hapa, you are allowed. I can see akona crutches, the other child is like this. Your picture we sema every, that is has a max. And then OSCES is not about it kusema tu cerebral palsy. They want you to see how you arrive there. So each thing ikona max. So akikwambia describe yes mjinga hapa hii ikona max. So you must describe what you are seeing hapa. I can see a baby which is in an abnormal gait. Another one is seated, the head is facing the other side with different gaits. Okay, Evo. I'll have two differentials. Utasema, from this picture that I've described, I think there's a cerebral palsy. There can be a tetanus picture here, Evo. What is the anatomical basis of this presentation? If it's cerebral palsy, utasema the anatomical basis of this presentation is, it comes because of either prenatally or postnatally, where we have an injury to the part of the brain, which now affects with the movement. That's why the child or the baby has certain diverse gaits, because maybe part of the brain has been affected, which is permanent, but it's non-progressive. And yeah, so now that's una describe how cerebral palsy comes about. Tasema hivyo. If it is the cerebellum imekuwa affected, this watoto hawataweza kuandika, they can't write, they can't do fine motor. If it's any part of the brain that's been affected, what causes it? Before inaweza kuwa maybe mtoto akiwa kwa tumbo, there was an infection, there was hypoxia, there was anything. Postnatally vile alizaliwa, the child maybe got trauma, maybe. So what led to that permanent damage in that part of the brain? And it is non-progressive. What are the types of cerebral palsy? Kuna the ataxia, kuna those other three types zote. You tell the examiner. Kuna wale wako ataxic, kuna wale wako athetoid, kuna wale wako hiyo. So your content now sasa comes in here, cerebral palsy. One radiological investigation tambia hapa, the most important thing we do is kama ni prenatally, mtoto kwa tumbo, maybe at that time tunaweza fanya ultrasonography, we pick it out, or kama mtoto ameshazaliwa, you can do a MRI of the brain and spine, CT scan, like that. So your content inakusaidia. So we can go to the next slide. If there's any questions, anything, pia mnaweza nisimamisha. So this is also an exam. Me, I got this question, and it was Dr. Laigong. Immediately I entered, nilipewa tu hii picture. Unaambiwa sasa describe what you see. Please unaona hii kitu, describe it. Before ukimbile ku answer questions. What are you seeing hapa? Just use your macho. What are you seeing? I'm seeing here there's a baby, hair, normal hair distribution, but there is a swelling at the back. I remember mtoto wangu same alikuwa na line kama huyu, alikuwa na IV line. So unasema, and then is in which side amelala ako hivyo. So please, most of your these stations are picture utambua, describe, usiruke, and those are marks. And then after you utambua, what is your diagnosis? Kama this baby, it is encephalocele. It's encephalocele. And then what is the clinical presentation? How does this thing come about? So this thing is more of embryological, sindio? The neural tube defects, whereby at 28 days watoto wakizaliwa, the neural tube is supposed to close, but now it's not closing correctly. Now we'll have content of the brain that is now herniating, coming to the skull. You know, the embryological basis that haikufuse. So this thing came. So kama imekuja hapa sasa mtoto, how will he present? He will present with features of issues with the brain that is not in the correct anatomical position. So the child might have delayed development stages. This child can have speech problem. This child can have visual problem. Is blind because this is on the occipital side. So this child can be irritable. This thing. So once you know the pathophysiology, Anencephaly, there is no brain completely for that baby. But this baby, the issue is the brain has herniated. Hapo the neuroectodermal, hizo vitu za embryo. So hizi vitu haziko close vizuri. So imeherniate into the skull. What investigations will you do? Then after that, utasema the investigation that I will do is the MRI of the brain, CT scan. Why the MRI? Because we want to know hii brain hapa yenye imeherniate. What is the content that iko hapa ndani ya mtoto? What is inside? So once we know what is inside here, the modality of treatment is we do a surgery. So, but before you do the surgery, you must know the area that you're operating hapa. What is, because this brain has to be taken back to the original position. So the treatment watakuuliza hivyo. So these pictures are so many. I can't predict which one will come. So it's you now to sit down and go and read. Kuna nyingine ya measles. You can find mtoto akona varicella. You can find mtoto akona rickets. Mtoto akona, they can give you whatever they feel like to give you. So Dr. Bilo has just texted me. Ameniambia he has joined the other meeting with Prof. Nduati. So this case, so one of your exam ukingele day ndani, just expect pictures that will come, and those pictures are so wide. It's just to pray hard that you get a picture that you know. And we can go to the next slide. So now your exam, one part ni hizo random pictures zitakuja. So take time here. Remember, we used to translate, car with your colleagues, read as many pictures, and then don't just cram the pictures, know the content. Now by now everyone has content, so have your content so that ukipata picture after you describe, you know what to do. The other thing is station 3 is analysis station. Now they want to analyze your skills to analyze things, because there's no doctor in the world who works and he can't analyze. So the pictures for me, these ones I got them from online, but they are good pictures, yeah, for examination. I think the team that has just finished Shaikina Sadruddin, the 6 years, please get in touch with them, take those pictures from them. Those pictures, kuna a whole picture ya pediatric, like you can sit the whole day 4-5 hours unapitia tu hizo pictures. Hii ni nini varicella, hii ni nini measles, hii ni nini rickets, hii ni nini hii. So I think the team, they must have, if I get them I'll share, but some mimi hizi nimetoa tu online, but I remember there used to be a PDF. So that's one side of the exam, and the other one is analysis. So analysis station is chest x-ray. So please don't go to that exam kama haujui kuinterpret x-ray. Every day that you do the exam, every day, day 1, day 2, day 3, x-ray will be there. So I've already given you one leakage. Every day x-ray itakuwa, but x-ray zitavari. Wanaweza leta x-ray of tetralogy of Fallot, kesho wataleta x-ray ya TB, the other day wataleta x-ray ya pneumonia. Kama this one is a pneumonia. So you must know how to interpret x-rays. I remember mimi nilikuwa na Dr. Bashir Admani, it was a foreign body x-ray. So every day, your exam, hiyo ni one leakage, every day x-rays will be there. Hakuna siku yako, the case will be different, but x-ray will be there. So now we go through this x-ray haraka. So utapewa your history. Utaambiwa a history of pneumonia is given. Maybe Kamau had difficulty in breathing, SpO2 82, played with his cousin 10 days ago, or there's another one ya TB. Wanasema maybe Kamau had a cough for 2 weeks, history of contact with the uncle who was coughing, weight loss, and respiratory distress. So after that, unapewa sasa x-ray ya TB. Or ya tetralogy of Fallot, anasema a baby surgery was done 2 days ago, and after the surgery, the x-ray was done, and this is the x-ray picture. So interpret. So identify the specimen and comment on the quality of x-ray. Describe the respiratory system related finding. What is the diagnosis, and explain. Now name one test to confirm the diagnosis. So this one, so how to approach an x-ray, I'll I'll share with you a mnemonic. Is the mnemonic that we usually use. That I think my other presentation here, laptop has it, but later I think I can share with you. So ukishapewa hivi x-ray tunatumiaga formula inaitwa A B C D E F G. So that thing, there's a video ya osmosis I will share. I think Ibrahim nikumbusha, I will share a screenshot of that formula niko nayo, na because of time sasa ndo I'll just say it overhead alafu baadaye mtapitia. So ukishaingia hivi kwa exam, you read the history, alafu Dr. Admani wherever they are atakupea laptop yake. The laptop has an x-ray, so atakuwekea hivi akwambie sasa interpret this x-ray for us. So same way, hakuna haja kukimbilia, even if you know this is a TB, hiyo ni 1 marks. They want to see the steps. Now how do you describe that x-ray one by one hadi mwisho? So the first thing is you unasoma, you assess the x-ray, whereby unasoma the information of the patient, the age, when was it taken. So after that unasema the view gani, anteroposterior, kuna lateral. I think this picture nimetoka this PowerPoint kituma na simu inakata, but this is a lateral view, this is a, kama sijakosea, is a anterior or posterior anterior, yeah. So utasema the view, what is the view, and then make sure please the first thing soma the biodata ya huyo Kamau, 10-year-old, taken on 16th April 2024 at 10 a.m. After that sasa unasema which view, is it a lateral? Mostly wanaleta hii antero posterior view. After that you assess the quality of this x-ray. Sasa x-ray, what quality yake iko aje? Quality sasa, how do you assess is number 1, kuna vitu kadhaa sasa tunaangalia. Number 1 is unaangalia that this x-ray, kama ni hapa sasa, this the spinous processes hizi, are they equidistant from every side? Are you able to at least count 10 ribs, posterior 10 ribs? Kama this one, at least you can count 1, 2, 3, 4, 5, 6. This other side same, you can see. High. The lung fields, unaona how good they are. Unaona hapa the view, hapa kuna black, hapa kuna black. Alafu the bone. Obvious kwa x-ray, bone inaonesha ile white, bone inaonesha kwamba that place light ilikuwa inapata wakati ngumu kupenetrate. Unlike the dark, hizi za dark inamaanisha these are the lung fields na light was able to penetrate very well. Haya, ukishaangalia hivyo, the rib cages angalia, unaona vizuri. The child, some x-rays ya watoto unaona inapinda. Obvious not for example, but in your practice unaona hii x-ray imechukuliwaje. This is a lateral view, I wish ni kitu. So make sure you assess the quality. Alafu image, is it too bright, too dark? Kuna zingine these lungs inakuwa so dark, so excess dark mpaka hata you can't tell, or others are just excess light hata tuwezi jua, like kama hii angalia, this is the spinous process, this is the clavicle, this is at the posterior ribs, this on this side sasa, this is the left side of this x-ray, alafu this is the right side. So and any x-ray unafaa ujue, like kama say the way you are seated, your right is not the exact right, your left is not the exact left, because of, you need to know. Kama say my right hand is the left of the patient, my left hand is the right of the patient. So this side that I'm pointing is my right hand side, but it is the left side. So hapa sasa kuna structures that will describe that are found on the left side. Ukishamalizana you come to B. B kazi yake ni bone density, which nishafanya. Angalia the bone, angalia the clavicle, angalia the posterior bone, everything ya bone. Unaona hapa the bones are well captured. Alafu the body mass, B. Body mass ni the fascia. Angalia hizi. You can tell hapa hizi fascia, the body mass is well, angalia iko smart mpaka juu. Angalia this body mass iko sawa hadi hapa iko sawa. So, C is the kitu inaitwa cardiac seal-how. The cardiac seal-how ni hii sasa. Is this one. This is the cardiac seal-how. So ideally, the cardiac seal-how ni mahali the cardiac iko. Ideally, it should be, unaona ukichora diameter from hapa, this costophrenic angle mpaka hapa, this diameter. Inamaanisha the cardiac seal-how is just from hapa to hapa. This lung has a pathology, that's when you make hapa. So the cardiac seal-how from hapa mpaka hapa should be less than 50% of this diameter. Anytime that this cardiac cell house is more than 50%, it means there's a pathology hapa. So kama this one hapa, this right side, this roll right side kuna consolidation. This is a consolidation. Consolidation meaning that initially niliwaambia that light inapata hard time kwa bone, but ikifika kwa lung, the tissue lung huwa ina penetrate well. What is making this side to be white? Bona this lung haiko smart kama hii. That we have the D is the diaphragm. So C is the cardiac cell house. Unaangalia the cardiac cell house. Kama ni tetralogy of Fallot, angalia this cardiac cell house. Unaona it is more than 50%. It's a boot shaped. So unaona hapa kuna something hivyo. D is your diaphragm. This diaphragm zinafaa kuwa nzuri like this color. That's very nice. Hapa haiko. What's not happening? There's another one for pleural effusion, and this I think in my baadaye nitatuma, you can also check them. So D is you assess this diaphragm. Kama kuna maji pleural effusion, it displaces this one. Haya. E is effusion. Yenye sasa niko naongelea, if there's any effusion, you check hapa chini. Alafu E is for equipment. Kama kuna any, kama sasa sometimes kuna watu watapata x-ray yenye mtoto amewekewa nasogastric tube. Kuna foreign body kama yangu. So hizo vitu kama wewe hujajipanga kuwa rada pa, you must know hapa. Alafu I forgot kwa the mnemonic ya air pia unaangalia air. Air should not be found where it is supposed to be. Like air should not be air if iko hapa. So anytime you see air hapa ndani, it means these are pneumoperitoneum, pneumothorax. Hizo ni surgical emergency. They should not be there. So you assess kama these all lungs kuna anywhere kuna air. So for hapa E ni equipment. Pia unaweza angalia kama kuna any console, anything, any foreign thing unaweza angalia hapa. Kama sometimes unaweza pata kuna lung tumor. Unaona hii kitu ni black, but unapata hapa kuna circle. Hapo inamaanisha there is a tumor. Kuna kitu black hapa. Ama mtoto amemeza coin, kuna kitu hapa. So look for any foreign things. F is the lung fields. These lung fields yenye niliongelea, they should be dark, nice, with their diaphragm. If now this lung field is so good, angalia hii, what's not happening with this lung field hapa? E, F, G. G is what sasa? E, F, G. G was... G, why am I forgetting? G was standing for something here. That one I think we'll check later. I forgot G was... Mtu anasema you can't see anyone. Mnaona hiyo the green pointer? You can see my... Nikifanya hivi mnaona kitu? Hello? When I'm describing anything with my cursor, mnaona?
We won't be able to see because someone else is screen sharing.
So are they able to see? Wanaona hii kitu nikidescribe? They can't see. Let me see kama I can share this part kwa... This will stop other screen sharing. Do you want to continue? So, wacha nione kama mine itaingia. Sasa inaonekana yangu? Is mine visible? Hello? Hello?
No, Dr.
No, Doc.
Okay. So I had a nice one.
Try now to share.
So let me do so. Who can share? Oh, hapa nimeona host only. Wacha ni ama ni all participants. Who can start sharing when someone else is sharing? Host only. Wacha niweke all participants. What about now?
No, we can't see your screen.
Oh, la, 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 la.
Okay. Do you want to share it with us to screen share for you?
So I share that screenshot. You do your A, B, C, D, E, F, G. So A, assessment of data, image quality, A, where it should not be. Alafu your B is the bones, the body wall. C is the cardiac silhouette and size. We said if the size is more than 50%, it should be less than 50% of this diameter. Unaona this other image yenye nimechora ma great vessels mali ziko, you'll find that haina consolidation. So the diaphragms are so good. Angalia the diaphragms are so good. So from this line ukichora diameter from mahali this kasa iko up to the stretch mpaka huko mwisho, draw a diameter that whole diameter, and the cardiac silhouette hapo, whereby we have the right ventricle chini, these two border unaona hapo from inferior IVC, inferior vena cava, and the left ventricle, that is the eospaciotendonator. This diameter should be less than 50% of that whole diameter. So the cardiac silhouette angalia that place. Alafu your diaphragms angalia, they should be so good. They are so, the curvature angalia those diaphragms angalia venye ziko, that total malena point. Look at those, assess those diaphragm please, because kama kuna pleural effusion in interfere with those diaphragm. The costophrenic angle ni hiyo angle ya hapo mwisho, whereby initially the cast hapo, those angles zinakuwa kama kuna pleural effusion ina interfere na hiyo. So assess your diaphragm. Angalia this small image hapa, this image for D, amekuchorea hizo diaphragm how they should be. Angalia those white dotted lines, your diaphragm zinafaa kuwa smart kama hizo. E is the equipment kama mtoto akona nasogastric tube, akona this other tube ya kutoa pleural effusion, the chest tube, the nasogastric tube, all of these tubes angalia. Effusions nishaambia mahali pa kuangalia. Look at it, usually displaces that one. I have another image, but here nitawatumia baadaye because of time. Alafu your lung fields, angalia the lung fields kama this one, angalia they are dark, well, ziko sawa. Haya, angalia the heart, where the heart is lying, the heart mahali inakaa, angalia. Alafu you come and name your great vessels. The great vessels sasa, all of them iko hapo. So unaona the right side and the left side. So on the left side mahali kasa iko, uko juu inaanzaga na kitu inaitwa, all this is iko kwa osmosis. So hakuna miracle. Your free time utakaa chini, osmosis 8 minutes, atakufunza hizo vitu zote better than me. So hapa ni aortic arc, the aortic arc inaanza hapo juu, the pulmonary artery, the atrial appendages, the left ventricle. Alafu on the right side of the heart kuna superior vena cava, utaona ascending aorta, inferior vena cava, alafu kuchini the right ventricle. So those are your great vessels on the left side and on the right side. Yes, I think that's all. Actually, we can go back now to the other X-ray neonations are the pathology. So hiyo is just osmosis, 8 minutes, and life goes on to other things. Sasa unaenda mambo mengine. Kishaangalia hiyo. Sasa ndo hii. So after ukishafanya hiyo your approach from the biodata, I can tell you hii station nabeba 25 marks. Don't go there and say pneumonia na unyamaze. All those steps they wanaangalia from the biodata. Hiyo yote A, B, C, D, E, F, G. So each one ukisema ana mark 1, ana mark hivyo. Haya. So now ukishafanya mpaka G, ukiangalia kila kitu, so the obvious pathology hapa ni we have a consolidation. Hapa I hope aweke kasa. The person present hapo, put hapo that area. So this is the lower right lobe. Kuna consolidation hapa. So this one is a typical lobar pneumonia hapa. Kuna consolidation. That's why from this history you connect it, unaona hiyo. Sometimes sasa assignment nitawapatia sasa assignment. So this one is an obvious consolidation on that one. After ukishachambua hivyo utasema hivyo and you support it. So now the assignment is this. Write somewhere at your free time, angalia x-ray ya pleural effusion. Okay, so okay, sorry. So for English, so during your free time, I thought everyone understands Kiswahili, sorry. So during your free time, take some time and go and check an x-ray of pleural effusion. Check an x-ray of tetralogy of Fallot. Check an x-ray of TB. Check an x-ray of foreign body. Approach is the same. How to elicit the finding is the same. A, B, C, D, E, F, G. The only thing that you are required is to make sure that orient yourself. Now this is a pneumonia. You can have a pneumonia with a pleural effusion. So you can have one with consolidation and a pleural effusion together in the same X-ray. Because one of the complications of pneumonia is empyema, pleural effusion, lung collapse, even lung collapse. So to your free time, how does a lung collapse look in an X-ray? How does a consolidation look in an X-ray? How does a pleural effusion look in an X-ray? TB in children. Foreign body. I think I've done my part. Every day that you enter that example, X-ray will be there to say hi to you. So you must know there's no shortcut for X-ray. So you can go to the next station. So the other one is neonatology. So for neonatology, obviously wanapenda, they'll ask you on neonatal resuscitation. So be given a history, term newborn with meconium stained liquor and it's not breathing. Manage this baby. Neonatal resuscitation. So hapo wanasema on A, there are no secretions in the mouth. On C, the heart rate is 100 BP. And now the baby is pink and crying. So all this, they should not stress you. All this case you'll be given, what is needed from you is to understand the examiner anataka nini. Is the baby breathing? That's why you ile mkisema A, airway, is the baby breathing? Hizo vitu zote. So this session now is a practical session and your skills are required and yeah. And ukishaiva neonatal resuscitation, don't stop at there. Sometimes wana change. Kama during our time tulikuwa tumejipanga na neonatal resuscitation, wakaleta insert an NG tube. The same manicure, lakini wanakwambia wanakupatia sanitizer, an NG tube, a towel and everything. Then wanakwambia weka an NG tube. So skills, this is just skills. So alafu iko tu pale chini opposite immunology in a group of 10 you go there and yeah. Then before that watch videos. I could have loved nikuje lakini sasa time ndo shida kidogo. So if Dr. Bilo, I'll speak with him pia atakuwa available because he's based in KNH. He can come and assist. Pia your self initiative nyinyi bora msilete vurugu ama crowd. Just have a good, the chair lady, chairman, organize the team in group of 10. Maybe in a week thrice 7 people mkienda in 2 weeks will be done. And there you can learn a lot of these resuscitations, kuweka NG tube. Alafu kuna ingine pia they surprise people. Sometimes they can just tell you examination of the newborn head. Examination of the newborn head. So what do you look? So neonatology, by the way, during my time, just know everything in neonatology because they will come. These other ones, they may be so wide, but neonatology will be there. There was a station of with Dr. Lavin about neonatal jaundice, how to interpret the neonatology graphs. Hiyo ya jaundice, how do you interpret these graphs za jaundice, neonatal jaundice? So anything to do with neonatology, just please Eva, and there are very few, and they will come. Those are the sections that unaweza patikana off cut. So I think that's all. We can go to the next station. So you need practical. This is a history taking. So history taking is a rushiwa. Unaweza kuambia 4-year-old present with a 1-day history of abdominal pain, nausea, vomiting, and low-grade fever. What additional history will you ask for in respect to only one system? Give 2 differentials. So this is a history taking, very basic. Utaulizwa tu hivyo, straight to the point, unaweza kukuuliza. Sometimes for pediatrics, history taking systemic exam, wanaweza chorea kidogo, but just prepare yourself. Wanaweza chorea, walete vitu zingine ambazo we've been speaking about, but either way, ikikuja, just take those points away with you. Carry them away with you. So like this one, 4-year-old with a 1-day history of abdominal pain, nausea, vomiting, and low-grade fever. What additional history will you ask for in respect to only one system? So now you just, if it is anything history taking, you just go with the same. The duration washakupatia. The chief complaint, the duration they've given you. So now you just go to the HPI. Your HPI should have 5 things. Number 1 is Socrates, symptomatology. So your abdominal pain, utamuliza, when did it start, where, describe the pain, how is it, hivo. Ukishafanya hivo, you are Socrates, you are done with it. After that, associated symptoms in that system. Now wanakuambia additional history will you ask for in respect to only one system. So this young baby, his problem is in the GI mostly, abdominal pain. So ask other symptoms in abdominal. So if you go to Hutchison 60 amtarudi kwa IMED, the whole chapter of GI, abdominal symptoms pekee, he has written over 10 symptoms: dyspepsia, vomiting, diarrhea, hematochezia, all of them. So you ask. After that, ask for any possible complication, ask for risk factors, ask for, like this young boy is a 4-year-old with a 1-day history of bottle feeding, history of hygiene, history of, it's just 4-year-old, 4-year-old, any exposures, any risk factors, you ask. After that, you ask for complications, kama kuna sunken eyes, lose hizo vitu zote, loss of consciousness, nini hizo vitu zote. All of it you inquire from it, and then you give your 2 differentials. Is it a GE gastroenteritis? Is it measles, or what else can, abdominal pain, nausea, vomiting, low grade fever? Yeah, mostly GE or any other inflammatory bowel disease you can have. Yeah. So I think this is, for a 5th year, it's so basic. So we can go to the next station. So if you get them, history taking 60 up as they come, they'll still ask you IMED. So lab result. So you can be given a lab result. The first lab result before this one is hapa chini nimeandika CBC interpretation. Complete blood count interpretation. You can be given WBC, white blood cells, platelets. You should know the normal duration of those parameters. So before even I start with nikupeleke kwa UECs, urinalysis, and this one, complete blood count. After that, you can go to your UECs. So hapa you can be given a photo of a child. I tried to create it. What are the clinical features? Facial swelling, periorbital edema, sick looking, most probably nephrotic syndrome in pediatrics. Alafu interpret labs. You can be given a UEC. Serum albumin 20. Normal 34 to 54. Now it is 20. Hypoalbuminemia. Urinalysis has protein. We have hematuria. What is the diagnosis? What is your diagnosis? Give 2 causes. Give other investigation, treatment modalities. So it can come that way. So expect any lab results you can be given. In our case now, if the albumin is low, urinalysis, proteinuria, hematuria. For me, I can say more of nephrotic syndrome. Causes of nephrotic syndrome in pediatric, the most common cause is which one? Alafu, anyone to give us the answer? Nijue watu wameiva. not like us who just minimal change disease. Yes, minimal change disease, 95% of cases, minimal change disease. Then two other investigation, you will say, the two other investigation will say I will do, you can do, apart from what they done urinalysis, you can do a complete blood count, you can do, what else for nephrotic syndrome? Because they are predisposed to infection, you can do either hizi mbona, we can imaging of the kidneys, we can do pia. Yeah, what else? Yeah, most probably. And then you can do the other markers that are creatinine, UECs. They can still be elevated because there's stress on the kidneys. Your CBCs, immune markers, is zote. Then two other investigations. Then treatment modalities, it is steroid. Steroid. If we have steroid resistant nephrotic syndrome, you can give immunosuppressant cyclophosphamide. Yeah. So nephrotic syndrome, so the assignment is nephrotic syndrome versus nephritic syndrome. So what is a nephrotic picture? What is a nephritic picture? So I think that's an assignment in pediatrics. Yeah, and then, yeah, but so that's a lab result. You can do it to the next. Next, Sabina, second last, alafu tumalize. Child health. There is no day you'll go to OSCES and you will not find a child health question. I know many people are attacking child health. Some don't want to read child health. Many people don't. Many people don't want to read child health. Others, they haven't some time read child health, but I can tell you, if you read well child health, I'm sure you'll encounter like two stations for child health. Two stations for child health. So don't you be found unaware that you went inside there and then they give you a question for child health and you have no idea. I had this question for me with Prof. Nduati. This was our year, we were given this question. So luckily I had read this question, otherwise we have just looked at each other. So 4-month-old neonate with the loose stool, given bottled water and porridge, also being breastfed, not vaccinated at all, no travel to malaria endemic area. All, no travel to malaria endemic area, water source springs, has sunken ice and skin pitch of 2 seconds. No signs of shock and AVPU at A. What is your diagnosis? Two vaccines for preventing this according to WHO. GAPD is Global Action Prevention for Pneumonia and Diarrhea. Risk factors for this condition: counsel mother on improved water sources and domestic water treatment. So this question will come. So now for this chapter, 4-month-old neonate with a loose stool, given bottled water and porridge, also being breastfed, not vaccinated at all, no travel to malaria endemic area, water source springs, has sunken ice and skin pinch of 2 seconds, no signs of shock and AVPU at A. So what's your diagnosis? So you'll tell him or her that this is a case of a 4-month-old with features of mild dehydration. Because why mild dehydration? Because we have sunken ice, skin pitch 2 seconds, no signs of shock and AVPU at A, so we can't see severe dehydration, just mild, and Also, we have secondary to diarrhea, loose stool. Hi. So now you can explain like that, and each you justify. Why did you say mild dehydration? Because sunken ice. Why did you say diarrhea? Secondary to diarrhea because of the loose stool. And then 2 vaccines for preventing this according to WHO. This one. So this guy, this they really love. So 2 vaccines at his stage is rotavirus and measles. Rotavirus and measles. Because remember, the most common cause of infection in young babies is rotavirus. Measles in babies with severe malnutrition. Risk factors for this condition. So the risk factors are in your case scenario. So I remember that day I wanted to mention some risk factors, but she prompted me to stick with the case. I remember very well. So the risk factors here is, this is a 4-month-old neonate. He's being given a bottled water. So do we give bottled water to 4-month-old neonate and porridge? There should be an exclusive breastfeeding up to 6 months. Also being breastfed, but exclusive breastfeeding. So there's a risk factor there. Not vaccinated at all. It's another risk factor. Water source is springs. This water source, is it a good water source? Alafu has sunken ice and skin pinch off. Okay. Cancel mother on improved water sources and domestic water treatment. So this one, I just refreshed because just reading to few days to the presentation. So this in Bagadim, you will come across watawafunza. They'll teach you on improved water sources and domestic water treatment. These are improved water sources are like protected boreholes, stored, I think, the storage of water in well-protected containers. I think you know better. You know better. This thing, my knowledge, ilikuwa kitambo. It was long ago, and yeah. And domestic water treatment are like filtration, boiling, chlorination, use of solar, all of them. So you cancel the mother. Now you are supposed to not answer like me. You answer like a good candidate who is prepared for the exam, and you counsel the mother on what she should do, because she's just using, and I use water sources in springs. So springs are just natural water. So what other sources will you advise her? So these are, you used to present amongst ourselves PowerPoints. You make PowerPoints on water, PowerPoints on pneumonia, PowerPoints on TB, all those PowerPoints. Make sure you go back to them, read very well, and your answer. Next. So expect a question on child health. So there are things which are constant. You can't choose every day has child health question. So they might decide another day to bring like this question. 9-month-old child at risk of malnutrition, has moderate malnutrition, who is being force-fed and has no vaccination given till date. What is the diagnosis? Counsel the mother on responsive feeding. What vaccines will you give this 9-month-old? What are the causes of health system related missed opportunities for vaccination? 5 points. Yeah. So now we'll have a case like this. They can decide to bring a case on pneumonia. So make sure you have knowledge on child health. Yeah. So for this one, I tried to answer because I tried my level best to answer. Let me see. So for this one, the answer they were saying is yeah, so 9-month-old child at risk of malnutrition, has moderate malnutrition, who is being force-fed and has no vaccination given till date. What's the diagnosis? So the answer they gave was moderate acute malnutrition in a 9-month-old child. Missed of immunization is another. They were just like approaching the case scenario on what was not in the right direction for the baby. The baby had missed immunization, not vaccinated till date. There was a feeding difficulty, inappropriate feeding practice because there's a force feeding. And then at risk for developmental delay and recurrent infection due to poor nutrition and lack of immunization. But the diagnosis was just moderate acute malnutrition. Then cancel the mother on responsive feeding. You tell the mother to observe cues, avoid force feeding, encourage self-feeding, create a positive environment, all of them. So observe cues. Feed when the child shows signs of hunger, e.g. reaching for food, opening mouth and stop when full. Avoid force feeding because she's doing force feeding. Encourage, let the child try hold food on a spoon. It improves interest and motor skills. Create a positive environment. Offer food patiently. If the child refuses, wait and try again after some time. Consistency. Include a variety of a balanced diet with grains, protein, fruit, and vegetables. Then they ask, what vaccine will you give this 9-month-old? Catch up, because hajaipata any vaccines, has not vaccinated given till date. So at 9 months, the child is due and delayed for multiple vaccines. You can begin catch-up vaccination. Immediate catch-up vaccines, BCG, if not previously given, and if child is under 1 year. Oral polio, pentavalent, 1, 2, 3, rotavirus. You start him. PCV, measles, rubella, vitamin A, first dose at 9 months. So immunization, by the way, vaccines, they really love what people of child health love vaccines. If vaccines, they won't come in OSCEs, they will come in your MCQs when you're doing the written exams. So you must, there are some topics that you must know them in child health. Vaccines, you must know them. Breastfeeding. One of the days, child health question can come from breastfeeding. Read about ANC, antenatal. HIV counseling. So sometimes they usually have communication skills. You can be given a case scenario and says they want to assess your communication skills. So that's why they are saying cancel the mother, cancel the mother. You can be given a case scenario of an HIV, mother, cancel, Evo. I think that's all. That's all. You can go to the last station. The last station is a growth curve. There is no day you will enter the exam of pediatrics, irrespective of which day, you will have a growth chart. So there are some things I'm giving you free leakage. One day a growth curve with an obese baby. The next day they'll just watato obesity and nutrition. And then questions will come from that. So everyday growth chart will be there. So what is the weight, height, and what standard does it fall in? Basically, how to interpret the growth curve. How will you do replacement feeding for this child? It's a case. This one, I don't have a specific case, because myself, I need to go and reread how to interpret the growth curve. It's been a while. So, but growth curve, they will be there in exams. Then questions like this will come. What is the weight, height, and what standard does it fall in? How will you do replacement feeding for this child? Explain AFAS. If the case is, if it's under nutrition, they'll be interested in some questions they will ask you. If it's obesity, there's some questions they will ask you. If it's depending, so growth curve will be there. I think that's the end of my presentation. If you have any questions, clarifications, corrections, it's 2 years, 2023, 2 years ago is when I did my pediatrics. So if there's any corrections, I stand to be corrected because you have read more and you know pediatrics more than me now. So any corrections, any questions, feel free. So back to the React, the team, kama kuna any questions. If you have any questions, anything to do with exam format, anything, let me, I can answer.
Okay, I'm not seeing any question in the chat box. Anyone who
Sure.
has a question could unmute and ask kindly.
Yeah, you are the pediatricians. Me, I want to learn from you. Me, I just read things a few days ago. It's a lot for me to catch up in pediatrics. So any questions, anything you have? Good question. For ECG, rarely. But one surprise they might do sometimes is they can ask about mamas. Maybe you can be given an earphone. They can play a certain types of mamas for you. So during my time, there were days people were prayed for mamas. So it's the luck. So sometimes they can ask mamas just wakitaka tu kuamua tu what do you say? If they want like to make people to be alert kidogo. So sometimes they can ask mamas, but ECG rarely. Yeah.
Yes, we'll have the recording shared.
Ibrahim, do you have any question? Who do I remember from the class? Ibrahim, Chair Lady Samira, Difatah, Sophia, Nuru, kama sija. Who else? Do you have any questions? Any corrections, Pia? Maybe Doc, this point here, anything.
No questions from me. Just like to thank you for taking your time to take us through.
Anytime, welcome. Anytime, Dr. Bilope, we are supposed to join with him. It's only that he's been in another meeting, but he's always open to assist. He said he's always